The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks to everyone for listening to the show. Today, we're diving into a question that's been floating around healthcare policy circles for years, but lately it's getting louder, sharper, and honestly, a bit uncomfortable. Is value-based care actually real, or is it just the industry's favorite buzzword? And is it the answer to rising healthcare costs and quality metrics that are at the bottom of developed world countries? We will take our regular 3 breaks to help everyone consume all this a bit easier. So let's get right into it. Part 1, setting the stage, the big question. A recent Health Affairs Forefront blog lit a firestorm when it argued that value-based payments and even managed care are not going to solve healthcare affordability. That's a big claim, and depending on where you sit in the system, it's either overdue, honestly, or a massive oversimplification. Now, to be fair, some of the author's points are not wrong. Healthcare costs are driven by more than just payment models. Prices, technology, administrative overhead, all of that matters. But I think they miss something huge. They miss the fact that healthcare is in the middle of a long, messy, transformational journey. And the transformation never looks impressive in the early chapters. So today we're going to unpack the debate. We'll talk about what value-based care actually is, why critics say it's failing, why supporters say it's just getting started, and whether both sides might be right at the same time. Let's start with the basics. What is value-based care or value-based payments? Value-based payments are meant to move us away from the old fee-for-service system, the transactional payment model that has dominated healthcare for decades. And when I say transactional, I mean exactly that. You see a primary care doctor, that's a fee. A specialist consult, another fee. A surgery, multiple fees. Labs, imaging, hospital stays, each piece billed separately. In some cases, hospitals are literally paid line by line for services during a stay. It's like a restaurant where you don't just pay for the meal. You pay separately for the chair, the plate, the fork, and the napkin. And here's the core problem. When payment is tied to volume, the system naturally drives more volume. More services mean more revenue. That doesn't mean providers are bad actors, but incentives matter. Transactional payments tend to increase utilization, often beyond what's truly necessary. It is hard to blame a doctor or hospital for behaving as they do in this archaic and dysfunctional system. They also drive inflationary behavior because rising unit prices is one of the few levers available to providers to earn more money. So each year we have higher prices and usually more utilization. The two come together to create huge cost trends. Right now, we are seeing trends of 6 to 9% in healthcare in various insurance lines of business. And the latest report from the CMS actuary says we will see roughly 7% trends over the next 10 years. That's just not sustainable. And maybe most importantly, fee-for-service doesn't really care about long-term outcomes. Again, this is not an indictment of providers. Many doctors are compassionate and truly care for their patients. But the system as a whole does not treat patients for the long term. Patients' disease states are not truly care managed. They're not managed but checked in on periodically. Prevention is not emphasized. Once the service is delivered, the payment is done. Unless you have an extraordinary doctor, and even then, they are held hostage to bill, baby, bill, as Donald Trump might say. Overall, there is really no accountability in the system for what happens next. Now, let me be clear. We're never going to eliminate fee-for-service transaction payments entirely. Some services just don't fit neatly into alternative models. But CMS, Medicare Advantage plans, Medicaid managed care plans, and commercial insurers are all pushing towards something different, a system where providers are rewarded for efficiency and quality, not just activity. That's the theory. But how does it actually work? Let's talk first about episode-based and outcome-linked payments. One approach is to bundle payments around an episode of care. Take knee replacement surgery, for example. Instead of paying separately for the surgeon, hospital, rehab, and follow-up care, the system pays a single global fee covering the entire episode. Suddenly, providers have a shared incentive to coordinate care and avoid complications. It lowers costs and perhaps delivers better quality. In the old model, everyone focused only on their piece of the puzzle. In a bundled model, the whole team owns the outcomes and the costs. We're even starting to see early versions of value-based payments tied to drugs, especially in oncology. Imagine a cancer therapy where payments depend partly on whether the treatment actually controls the disease. That's controversial. It's complex, but it signals a shift in thinking. Outcomes matter. With that, we will take our first break, and when we come back, we will continue to talk about VBC models. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're talking about value-based care and asking the questions, is it real? And is it the answer? Let's get to part 2, comprehensive risk, where things get serious. Now let's move beyond single procedures or drug outcomes, because the real action in value-based care happens in broader arrangements between insurers, governments, and providers. This is where things start to get uncomfortable for a lot of people, because we're talking about risk. Primary care capitation is one example. Doctors receive a per member per month or PMPM payment to manage a population's care. Instead of getting paid more for each visit, they're paid to keep people healthy. Then you have shared savings models with accountable care organizations and other providers in the traditional Medicare system. You also have partial risk funds and full global risk arrangements between insurers and providers. Providers might receive a portion of premium dollars and become responsible for managing some or all costs for assigned patients. Do better than the target, you keep some of the savings. Do worse, you may owe money back. There are safeguards, stop-loss insurance, risk corridors, limits on exposure, but the philosophy is clear. Align incentives between payers and providers to drive appropriate savings. Quality metrics are layered into these models, sometimes adding bonuses, sometimes penalties. And yes, there are countless variations. Some providers only take upside risk. Others take full downside risks. Some contracts exclude high-cost services like inpatient care or drugs. It's complicated, it's messy, and it's evolving fast. So how big is value-based care right now? Here's where the hype and reality start to diverge a bit. Depending on how you measure it, somewhere between 35% and 45% of healthcare payments today are tied to some form of value-based model. Sounds big, right? But true risk-bearing arrangements, The ones that really change behavior might only account for about 20% of transactions, and penetration varies widely. Medicare Advantage is highly advanced, approaching about half of payments tied to value-based structures. Traditional Medicare is somewhere around the mid 40% range. Medicaid and commercial markets lag behind. Large integrated health systems are ahead, rural providers and specialists much less so. In other words, we're not at the finish line. We're barely past the starting gate, and that's exactly where critics come in. With that, we will take our second break, and when we come back, we'll tackle what some of the critics of value-based care and payments are saying. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We are talking about value-based care and asking the questions, is it real? And is it the answer? Let's get to part 3, the critics. Is VBC just a distraction? So some savings are reported for VBC and VBP in traditional Medicare. CMS says that in performance year 2024, that's the most recently reconciled performance year, shared savings program ACOs earned shared savings totaling $4.1 billion and saved Medicare $2.5 billion. As for a bundled payment pilot, the Comprehensive Care for Joint Replacement, CJR, model became 10 and had a small subset of hospitals in the pilot. Its successor, the Transforming Episode Accountability Model team, is now live in hospitals across the country. After a decade, studies show mixed results on the CJR program. CMS found that CJR generated an estimated $112.7 million in Medicare savings across performance years 6 and 7, or roughly 1,142 per episode. That beat the overall losses earlier, but CMS says the model did not lead to changes in quality of care on claims-based measures of readmissions, emergency department use, mortality, and complications. Other researchers say savings and impacts have been small, roughly $50 in savings per episode and 0.04 additional healthy days at home per patient. The Health Affairs Forefront blog makes a bold argument. Value-based care isn't bending the cost curve and might even be distracting policymakers from real solutions. They raise several points here, so let's go through them. First, many pilots haven't generated dramatic savings. Second, value-based models may be accelerating consolidation and empowering corporate intermediaries. Third, spending slowdowns don't appear strongly correlated with VBC adoption. And then there's the biggest criticism of all, prices. High unit prices, rapid technology diffusion, and administrative complexity drive unaffordability, and payment reform alone doesn't fix those. I've said myself that you can't outrun a broken pricing system. If underlying prices keep rising every year, value-based savings can get swallowed up. That's just a hard truth. But here's where the debate gets interesting. Because while critics say the evidence isn't there, supporters point to a different body of data. Take a recent Humana report. It showed a 24.3% decrease in inpatient admissions among Medicare Advantage members in value-based arrangements compared to traditional Medicare. That's a huge gap. Hundreds of thousands fewer hospital stays. Even within Medicare Advantage, value-based members had about 7.6% fewer admissions than those in non-value-based contracts. Humana estimates more than $12 billion in savings tied to these models. Now we're getting to real money. Now, skeptics will say, of course, a payer report shows success. Fair point. But you can't just dismiss the trend either, because if mature value-based systems consistently reduce utilization, that tells us something important. Maturity might be the missing ingredient. With that, we will take our last break, and when we come back, we will sum things up. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're talking about value-based care and asking the questions, is it real? And is it the answer? So let's get to part 4, the reality. Transformation takes time. So where does all this leave us? Honestly, somewhere in the messy middle. The critics are right that value-based care alone will not fix healthcare. We need price reform. We need stronger primary care investment. We need more stable universal access to insurance. And yes, Medicare's endless pilot programs sometimes feel like alphabet soup. Too many acronyms, too many metrics, too much administrative burden. But here's the part that often gets overlooked. You can't turn an aircraft carrier overnight. Traditional Medicare is massive. It is an aircraft carrier. Provider behavior has been shaped by decades of fee-for-service incentives. Expecting dramatic savings immediately is unrealistic. Some pilots have struggles. Others, especially more mature ACO models, are starting to show incremental progress. CMS continues to refine them, raise expectations, and push providers toward two-sided risk. And all that is a good thing. And then there's Medicare Advantage. Despite political criticism regarding risk adjustment overpayment, poor star performance of late, and the bad behavior of the largest vertically integrated plans, multiple studies suggest lower cost and improved outcomes in Medicare Advantage compared to traditional Medicare. Alignment between health plans and providers, or government and providers, seems to accelerate behavior change. And some research even suggests spillover effects into fee-for-service. Fee-for-service trends and costs are better because MA is changing behavior overall. Maybe that's the real story here. Value-based care isn't failing, it's just not finished. Healthcare reform isn't one silver bullet, it's a system of gears. Pricing reform, access reform, care delivery reform, and payment reform, all moving together to create a well-functioning machine. Value-based care is one of those gears, maybe not the engine itself, but without it, accountability disappears. So is value-based care real? Yes. Is it overhyped? Also yes. And maybe the most controversial takeaway is this. The debate shouldn't be about whether VBC works. It should be about how fast we're willing to push the system toward real risk and real accountability in all areas of healthcare. Maybe we could go a bit further and faster. Because as long as fee-for-service dominates behavior, healthcare will keep rewarding volume over value, transactions over quality, and we will remain the developed nation that spends the most and has the poorest outcomes. Essentially nothing to show for it. And that's a system none of us can afford forever. Most of us cannot afford it now. If you enjoyed today's deep dive, make sure you follow the show and share it with someone who lives in the healthcare policy world, because these debates are only getting louder. I am Marc Ryan. This is the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.